Kelsey. My name is Paige. I'm going to be your student physical therapist today. We're going to be palpating some structures on you today. I'm going to be in some areas such as up here on your lower back and ribs. I'm going to be on the back of your hips and then down below. Is that going to be okay with you today? Go ahead and lay your head down, your arms by your side. The first structure I'm going to palpate is going to be the PSIS. I'm going to come on top of the iliac crest, follow them down until I hit those bony landmarks. This is an important landmark because the posterior sacroiliac ligament originates from here, and from here I can then find the second sacral body. From there, I'm going to go inferiorly and then laterally to run into the inferior lateral angle of the sacrum. This is the other attachment site for the posterior iliac ligament, sacroiliac ligament, and then the gluteus maximus also originates off here. Then I'm going to go underneath the bottom of your butt cheeks. Is that going to be okay with you? Yep. All right. So I'm going to go with a flat palm underneath until I feel that bony end feel, and that is the ischial tuberosities. There is going to be the origination for the hamstring muscles, as well as the sacrotuberous ligament is also going to insert there. Next, I'm going to go up onto the ribs. I'm going to find the 10th rib, which is the last true rib. As I move back, I will run into the 11th and then the 12th rib. The 12th rib is the last floating rib. If I follow it medially, I will run into T12. This helps me be able to find the rest of the T-spine, or I can go inferiorly to run down the lumbar spine, and then I can find L5. L5 is a great landmark to know because there's a lot of lower back pain that can occur with the lumbar spine. And then again, I could go inferiorly and find the rest of the sacral body. All right, so now that my patient is supine, we're gonna do some structures on the front of the hips, on the sides of the hips, and then we will move up to your neck. Is that okay? All right, so I'm gonna come down on top of those iliac crests again. Now I'm moving anteriorly to find those ASIS, which are very prominent bony landmarks. This serves as the origin for two things. It'll be the sartorius muscle that comes to the medial knee, and then also the ilioinguinal ligament, which is going to be the superior border of the medial femoral triangle. And then for me to find the other insertion point of the inguinal ligament, I'm gonna be using the heel of my hand. I'm gonna move down your belly button to find these bony landmarks on your pubic bone. Is that okay? Yep. All right. So I'm going to be gentle all the way until my palm of my hand bumps up to those tubercles. I'm going to use my finger pads to make sure I can feel those bony landmarks. So that is going to be the superior border of the medial triangle. The sartorius is the lateral border, and then go ahead and bend this knee and cross it over. And if you can go ahead and adduct your leg into my hand, that's going to activate that adductor longus, which is going to be the medial border of that medial triangle. In here is going to be the important neurovasculature, including the femoral artery, vein, nerve, and some lymphatics. Here I could find the femoral artery to make sure that she's having adequate blood flow to the lower extremity. Now I'm gonna move up into the stomach area. I'm gonna go right under your ribs, and I'm gonna feel for a kind of soft, firm end feel of the liver. So this is an important structure to find because if there's tenderness of this liver, that may need a referral out to another physician because PTs won't have the ability to be able to treat for that. I'm gonna have you go ahead and lay over and go onto your side. I'm gonna use the flat palm of my hand to place onto the side of the hip to find that greater trochanter. It's gonna be the most prominent bony landmark. If I use my finger pads, I can find the details of that greater trochanter, which is super important for muscle attachments from the posterior hip. And then this is also gonna be a common place for referred pain from the lower back, the hips, and the pelvis. Go ahead and lay back on your back. I'm gonna move up to the neck. I'm gonna support the patient's neck here and head. I'm gonna go to the base of the occiput, and the first space that I'll feel is where the C1 spinous process is, and then moving inferiorly, the first bony prominent I will feel is the spinous process of C2. This is a super important landmark because if I move inferiorly, I can find the rest of the cervical spine from 3 to 5. Or if I move laterally, I'm able to run into the articular pillars, which is again another important structure because the cervical paraspinal muscles will move in this area. And then if you move more laterally, you'll be able to feel the individual facet joints. If I move more inferiorly to the last largest bony prominence right here is going to be what I'm going to assume is C7 spinous process. I can confirm this by moving up one vertebrae, and I can have the patient flex their neck, which that vertebrae pushes me out. They extend, it disappears. So because that one moves, I know that is C6, and then the lower one that doesn't move is C7. This allows me to, again, either go down the rest of the spine to find the thoracic vertebrae or go back up towards the rest of the cervical vertebrae. And then the last structure that I'm going to palpate is going to be the first rib. So if I go down here to the base of the neck, the first rib is the base of the neck, and I will get a bony end feel as I move anteriorly towards the clavicle. This rib is also important because it has the scalene muscles will attach at this location. Okay, so now that my patient is in a seated position, I'm going to palpate structures of the shoulder, elbow, and hand, and then move on to the knee, ankle, and foot. Starting with the AC joint, coming off the acromion process and the clavicle, I will meet up at the acromioclavicular joint. This joint is a common site for shoulder separation, and I can further go back and find other structures of the shoulder. Following this acromion process, turning into the scapular spine, if I palpate transversely across, I will find the supraspinatus muscle superiorly and the infraspinatus muscle inferiorly. The patient brings her arm behind her back. Following the scapular spine, I will end up on that medial border of the scapula. Going inferiorly will be the inferior angle of the scapula. Here, the teres minor and teres major will be attaching here. I can have her press into my arm to have that muscle pop out. Go ahead and relax. Going back to that AC joint, just inferior to it will be the subacromial space. The supraspinatus muscle tendon is running through this area and can be a site of impingement. Also, there is a bursa that is found in this area that can be common to have bursitis in this area as well. Using the palm of my hand, I will find the greater tuberosity. This bony landmark is an attachment site for the rotator cuff muscles and serves as the lateral border of the intertubercular groove. Moving anteriorly, I can go just below the clavicle and deep to find the coracoid process. This serves as the attachment site for the short head of the biceps brachii and the coracobrachialis. Now going down to the elbow structures, as I go down the humerus, I'll run into the medial epicondyle of the humerus. This serves as a common origin for the wrist flexors. If I go posteriorly from this point, I can find the olecranon process. On the lateral side of the humerus will be the lateral epicondyle. This serves as the common origin for the wrist extensor muscles, and from there I can go inferior to get a hold of the radial head. Here, I can have the patient turn their head in and out for pronation and supination, and I can feel that radial head rotating between my fingers. From this point, I could then follow all the way down to feel the shaft of the radius. Moving on to the hand bones, you can have the patient spread all of her fingers out, going straight into that anatomical snuff box. This will be the scaphoid bone. The scaphoid bone is commonly fractured from a mechanism of injury, such as the fall on an outstretched hand. This bone is common for weight bearing because it has a lot of articulation with this radius bone. Going on to the other side of the hand, coming off the ulna will be the triquetral bone. This bone is important because you can go on the palmar side to find the pisiform, which sits on top of it. And in this area as well, you will find the tunnel of Guillain, which houses the ulnar artery and nerve. Moving on to structures of the knee, I'm going to palm with my hand to find the patella. Moving down and then out to the sides, I can find the medial and the lateral joint space. On this medial joint space, I can move in more medially, and eventually I will be kicked out because of the medial collateral ligament is here. Moving back towards the patella in the larger portion of the space, I can have her turn her foot in and out to have that medial menisci push me in and out. On the lateral side, again, I will be pushed out eventually because the lateral collateral ligament is placed here. Using the palm of my hand, I'm able to find the fibular head. This is an important structure because the biceps femoris is going to be inserting here, and then this is also an attachment for the fibularis muscles of the lateral compartment. Go ahead and bring your foot up here. Going down the shaft of the tibia, I'm able to eventually drop off and find the dome of the talus. This is where the true ankle joint is, which is the talocrural joint. From the talus, this is part of the attachment for the anterior talofibular ligament, which is on the lateral side, just a little bit. This is an important ligament because it is commonly injured with a lateral ankle sprain and becomes taut with plantar flexion and inversion of the foot. Going on to the more lateral side of the foot, using my palm of my fingers, the most bony prominent I will find is going to be the base of the metatarsal, fifth metatarsal. It's going to be most prominent at the styloid process. This serves as that insertion for those lateral compartment muscles and is a common site for an avulsion fracture. Going on to the medial side, with my fingers and palm, I will find that navicular tuberosity. This serves as an attachment site for the posterior tibialis muscle, and just one finger's distance away, I will then find the medial cuneiform.